más interesante que BPH con los excelentes ponentes, pero bueno, hay que ver que hay unos profesores que están en línea esperando para participar y no pueden estar esperando toda la tarde. Vamos a empezar ahora con la sesión. ¿Podemos continuar? Usted me enseñó, ¿no? Que me ponga dura, me dijo, fuerte. Me dijiste, ¿no? Ok, muchas gracias a todos por estar aquí. Ahora vamos a empezar con la sección de andrología y va a estar de moderadora la doctora Katy Enríquez, una compañera nuestra muy brillante que se ha dedicado a la andrología y nos enorgullece mucho tenerla aquí. Entonces, we are going to call Professor David Barron, if you may. David? Huh? Yes, please. And you have a presentation now. Do you know? Did you know? But if, you know, you gave them the slides. ¿Tienes los?
Yeah, they could just put up the slides from yesterday. The slides in the back were the ones I was going to use.
Do you have it?
Yeah, they have it over there.
Okay.
Nah, I'm good, thank you. I just want to see the title for this one, because I had a couple, a number of different ones. You know, go this way. So was depression, right?
Is depression, addiction, and sexual dysfunction.
No. Rather than wait for that, we'll just go ahead and start.
You are right now here, right? Yes.
Yeah.
Here. Yeah.
Yeah, that doesn't.
Dr. Hopkins told me that you are also at Stanford Department.
Yeah, the Stanford Department of Psychiatry.
I'm going to present scenes.
Yeah, just do it
Yeah.
very short.
Buenas tardes, vamos a empezar la sesión de andrología. Mientras cargan la presentación del doctor David Barron, él va a hablar acerca de depresión, adicción y disfunción sexual, ¿sí? ¿Por qué las expectativas sociales de la masculinidad han moldeado la salud masculina mental? Entonces, el doctor David Barron, él es psiquiatra de la Universidad de Stanford en el Departamento de Psiquiatría, que está adjunto también a la Universidad de Western. Él es profesor en ambas universidades, así que mientras cargan las diapositivas, bueno, vamos a esperar al doctor Barron.
Thank you. Well, thank you all. It's tough late in the afternoon after a busy day, so I appreciate all of those who came here. And what I'd like to do is, very briefly, so we can stay on task, is Ingrid wanted me to speak about depression, substance abuse, and sexuality. I think that was the title, right? Yeah. Well, interestingly, when we look at depression and substance abuse and sexuality, there's a heck of a lot of overlap. So when we talk about depression, it becomes very important that we differentiate what we call big D depression. That's the depression that we would treat psychiatrically, the illness In the DSM, we call that 296.5, that depression, the illness, versus little d depression, which is, I'm feeling depressed today. I'm not happy. I wish I could be home with my family. Because even though both of them share some symptoms, there's a significant difference between someone who has depression, the psychiatric syndrome, versus someone who's feeling sad. In fact, for major depression, sadness isn't always the most common symptom, which most people think, well, if I'm depressed, I'm sad, because we use the same term. And I don't know in Spanish, I apologize, I don't speak Spanish, although I should. I live in Los Angeles. More of my neighbors speak Spanish than English sometimes. So when we look at depression, we need to understand depression, the big D, the illness, is not an uncommon. If you look at the WHO statistics, depression is always usually in the top 5 or 6, depending on where they study it and what they use. But depression is a very common disorder, and it's very comorbid with other physical illnesses. A very important point that we need to keep in mind as clinicians, we had a brief discussion at lunch today about this, there are many illnesses and medications that present what looks like a depression. The majority of the drugs used in cardiology have been reported as having depressive-like symptoms. So should we be treating someone who we think is depressed with medications when in fact what we might be seeing is side effect profiles or directly related to another physical illness? When we talk about depression as clinicians, we have many screening instruments. But what are we looking for? We're not going to be getting Hamilton, Beck, Zung, all the different screening instruments unless we're doing research. But we should be looking at this sense of a lack of joy, a decrease in the quality of life as a result of poor sleep. Now, the sleep dysfunction that you see with depression is different than anxiety. The anxious patient has a hard time falling asleep. I go to bed and I've got a million thoughts in my brain and I can't rest, I can't fall asleep. Once I fall asleep, I'm okay. I'm able to sleep through the night. The sleep disorder, the dysomnia associated with depression is what we call middle or terminal insomnia. Terminal not like death, but later in the sleep cycle. And what we see for those patients is they're able to fall asleep, but they wake up 2-3 hours later. And maybe they have a hard time getting back to sleep. Or they wake up very early in the morning, hours before they have to normally get up. Now, people for a long time thought, well, what is it about sleep that is so important with mood and anxiety? And it turns out that some of the work at Urological, I was fortunate enough to be involved in some of those studies, is during sleep, there's this thing called the glymphatic system. And it's the time when the brain flushes out the exact same molecules and proteins that end up leading to dementia. So a poor night's sleep is a whole lot more than, I'm not so rested. It actually sets one up for neurocognitive deficits, for mood deficits, and this has been well studied. And interestingly, restoring normal sleep is one of the most therapeutic things that we can do in a whole variety of things. So sleep, although many of us, we didn't learn a lot about sleep as we went through medical school, we now know this is a very powerful and important, not only as a diagnostic tool, sleep disorder is very common, almost ubiquitous when we're talking about a mood and anxiety disorder. But how do we assess for a good night's sleep? Do we have to put someone into a sleep laboratory and put all the diodes and bills? No, there is one question a good clinician should ask every patient when it comes to assessing their sleep. Do you feel rested? A patient can say, I was in bed 12 hours, but I can't get up. I need 3 cups of coffee and a cold shower. That the ability to monitor sleep is something any good clinician, any good medical student, do you feel rested when you get up in the morning? Mother Nature really allows us to monitor ourselves sometimes much better than we think we can. So the thing we want to know about depression, if we think it's there, is are they sleeping well? Have they lost interest in things they used to do? So it turns out one of the key factors of depression is the loss of the ability to have joy. Now, we can measure this in dopaminergic mechanisms and oxytocin, and we can show neuronal circuits through imaging, But from a clinician's perspective, it's something as simple as, are you still able to enjoy things in life? Well, I really don't like this pain I'm in, but I still love going for a walk with my wife or my significant others. I love watching a beautiful sunset. I enjoy a good meal. That's someone who's not likely to be depressed, because that is really one of the core symptoms, the loss of the ability to enjoy, to feel a passion for something. And in fact, one of the best psychobiomarkers of an improvement with depression is when patients say, I listened to a song yesterday and I really enjoyed it. It almost brought a tear. It reminded me of my wedding night or my son's football match, and I was there and he scored the winning goal. But that ability to tap into a sense of joy. How we feel, you as surgeons, Jewish doctors don't go into surgery. We don't like the sight of blood. But when you do a good surgery and you come out and you know you've done something special for that patient, you've allowed them to have a higher quality of life. That ability to feel that joy, you're probably not depressed. I've taken care of I worked in the Department of Urology at USC. Some of you might know Don Skinner and Indy Gill. These were colleagues of mine. I work with them. I know they've done a lot of work. And Isla Skinner was one of my medical students. So you know how old that makes me now. But they would send me faculty. Faculty would say, I do the surgery and, I think I did a pretty good job. No sense of joy and connectedness. That should raise a yellow flag. So we've got sleep, appetite, depressed people. Interesting, they say food doesn't taste the same anymore. It tastes bland. It doesn't bring me joy. Now, we know that dopamine is heavily, heavily related to a sense of joy. In fact, one of the things we talk about when substance abuse is a concept called RDS, Reward Deficiency Syndrome. And what it has to do with is the homeostasis of dopamine at the synaptic cleft. But what it really matters is its activation of circuits that go to other parts of the brain, which is why you explain when people are depressed, they'll say, you know what, it's just harder to do things. They walk the way I'm walking now. Their head is down. Speech seems to be a bit more difficult. It's like they have the weight of the world and they don't enjoy. They're not sleeping well. Food doesn't taste particularly good. Interestingly, when women get depressed, they're more likely to overeat. And we think we know what might be going on with that, but that's a topic for another discussion. They will disengage. You'll see patients who start saying, I better get my life insurance policy up. Now, that can be a yellow flag for other, and not all suicides, I want to end my life. Many patients say, I want to live, but I don't want to live like this. I don't want to live in pain. I don't want to live without being able to have a romantic relationship with my significant other. So they're not actively suicide, but they have thoughts of, I don't want to keep living like this. We should pay attention to that. Interestingly, we talk about substance abuse and sexuality, as Ingrid wanted me to address. The loss of libido is a biggie. You will very rarely find a depressed male who will have a high libido. What they will say is they've noticed a decrease because, again, they can't enjoy it. Why have sex if it doesn't feel good? Thank the heavens it does feel good. It allows the population to keep going. So when a patient loses that ability or doesn't care about sexual functioning, none of these are diagnostic per se, but they're pieces of a puzzle that as a good clinician we put together. Their ability to relate to others. I've seen so many depressed patients who they'll come in and I'll say, hi, Dr. Barron, my family doctor thought I should come talk to you. Oh, something's not right here. Now, should I make a diagnosis based on that? No, but I should start thinking about it. And when you ask about sexual functioning, I like to look at the joy factor. There's a whole new field within psychiatry called positive psychiatry. I'm old enough now to be one of the people who've been heavily involved with this, promoting it nationwide. Internationally now we have a number of colleagues, and they say, do you still enjoy it? It's like sleep. Don't say how many hours were you in bed. Were you rested in the morning? When it comes to sex, do you still enjoy sex? Well, yeah, I mainly do it for my partner because I know he or she enjoys it. That's different. So what we want to know when we're measuring a mood disorder is not how many times they're having sex, but do they enjoy it? If they've lost the ability to enjoy it, then we better start at least considering, is there a mood disorder? So sexual functioning, a critical kind of emotional biomarker of a mood disorder, much less so with anxiety. Anxiety, maybe if there's performance anxiety. I worked in the Middle East for quite a while. I do some work in Cairo, and oftentimes you'll see individuals where they have performance anxiety, not depression, so they have an avoidance behavior. I avoid sex because I'm afraid I'm not going to be able to perform as I should. That's a different animal. When we talk about substance abuse, when we talk about abuse, not just substance use, I enjoy a glass of wine or sangria with a meal with my friends, that's not substance abuse. What we're looking for when the patient's depressed is, why do you drink? Well, you know, when I drink, it helps me feel better. How do you feel when you're not drinking? Not the way I'd like to feel. Aha. We need to explore a bit more with that. Because substance use can be, not always, but can be a form of self-medication. Why is alcohol so popular worldwide? Because it makes people depressed or suicidal or has them hallucinating? No, we take a drink, we relax. That part of us that makes us feel tight, we go afterwards, we have a few drinks, we laugh, we relax. That's an enjoyable process, and that can be directly related to dopamine homeostasis within the synapse. So there's an interesting biology to this. Now, when we talk about depression, know that it's pretty darn common. Interestingly, and I've developed some depression screeners, so by way of full disclosure, I'm not going to talk about those. I do a lot with athletes, with the Olympic team and a number of professional teams. And what we need to understand is how we assess is as important as who we are assessing. So in your field, as surgeons, you can look at the lesion. In my field, we don't very often have black and white. We have many shades of gray. When does a symptom become a syndrome? When do symptoms require treatment? I've got urinary, please.
I can answer that as a surgeon if I grade high in psychiatry. When it interferes with the daily activity.
Exactly right. Why do we go into medicine? Hopefully many of us go in, other than it's a nice career, our parents will be proud of us. But part of the reason we go in is we want to impact the quality of life of our patients or our communities, depending on where we go, or our students that we teach, regardless of how we do it, whether we're a surgeon, an internist, psychiatrist, fill in the blank. Maybe the pathologist, they're a little further down. But we go in because we want to affect quality of life. So that's what we should be assessing. How are mood symptoms? If someone says, you know, I'm not quite as up as I used to be, I don't enjoy things quite as much, but you know, I go into work, work's okay, I've got a decent relationship with my family, I'm able to do some of the things I still enjoy, maybe not as much. All right, maybe that's a patient we observe, just like if they had urologic symptoms. All right, let's just keep an eye on this, because I want you to enjoy your life. I'm your doctor, and I'm committed to your quality of life, and we'll work together on this. Allow the patient to talk about it. In our field, sometimes the best information we get is just asking a simple open-ended question and letting the patient talk. And not only what they say, but how they say it. And the analogy I used to use for medical students is, imagine you go to the casinos. I know we're right here. I live close by to Las Vegas and Los Angeles. And someone goes in, they said, you know, you just won $1 million. Patient comes in and says, I was sent here, my wife went, I hear you just won $1 million. Yeah, I just won $1 million. Well, what do you think about it? Well, I'm sure my family's going to be very happy with it, and I'm going to leave a lot of money to my kids, and that's really good. Now, is that the same response as a patient comes in and says, I hear you won $1 million. Doc, can you believe it? I'm a millionaire. Everything I always wanted to do for my family, I'm going to do. So it's how it's presented plays a very important role. I want to end, because we're just about out of time now, with treatment. So the problem with depression, when we went through the decade of the brain in the 1990s, I was the deputy director of the National Institute of Mental Health in DC, but I do a lot of work with the World Psychiatric Association and the World Federation of Mental Health. We went through this period where depression was just you give the right pill. They used to have TV ads in the US that would have the little Zoloft pill, and patients would come in like, well, I'm a quart low of oil in my car, so just give me Zoloft and I'll be fine. It's much more than the medications clearly have a role and are effective. But let's be honest, we know some of the most significant side effects of antidepressants are loss of libido for men and for women. So if you look at the data that's come out very recently, we got a new book coming out on it, just Oxford Press, looking at emotional aspects of mental health in men. Exercise, enjoyable exercise, comes out about as good as most antidepressants, particularly from mild to moderate. It's very severe, not as much. So what we need to be looking at for treatment is not just, here's the magic pill, take this antidepressant, call me in 3 months or call me in a month. No, it doesn't work that way. Psychotherapies can work. Cognitive behavioral therapy, which is very manualized, easy to do. You can actually get them on computer programs now. I don't think it's the same as talking, but maybe it's just job security for me to come to see us. But the treatment should be multidisciplinary, looking at not having the patient feel like a patient, but I always frame it, no, you're depressed, we need to treat your depression. What I say is, you're not experiencing the same quality of life that I think you should. Do you agree? Well, I'd like to. Then we agree on that. So what can we do to improve your quality of life? And then I get into sleep, exercise, social relationships, very important issue. Connectedness with not only friends, but with other family members. The use of substances, whether it's abusive or maybe a little too much. Sleep and nutrition. So they're the 6 pillars of lifestyle psychiatry, but I'm going to stop here. Maybe we'll go over those. But it's very simple. And it's not about being diagnostic or pathologizing a patient. They're already worried enough that something's wrong. But to work with them to focus on that more important issue of you're concerned and want them to be concerned about their quality of life because they deserve it. Thanks very much.
You know something,